Assalamu alaikum wa rahmatullahi wa barakatuh. We will discuss today nutrition in surgery. This is an important topic in surgery. The pre-operative and post-operative nutrition for surgical patients. Nutrition affects outcome of surgery. Even when the surgery is done well, the nutrition affects the outcome of surgery. Malnutrition in surgery. Malnutrition in surgery. Most of the patients who going surgical operation are fairly nourished, can withstand stress of surgery. During surgery, there is a stress, so this stress affects the nutrition status of the patient. If the patient is malnourished operatively, he will this malnourishment is increased post-operatively, and this is leads to post-operative complications and delay wound healing. As you know, the wound healing depends on some nutrients, proteins, vitamin A, vitamin C, and other nutrients, and this affect wound healing of the patient. So the nutrition is a crucial topic in surgical patients. What are the causes of malnutrition in surgical patients? The first cause is starvation. Starvation occur in surgical patients, maybe due to poverty or senility or ignorance. Anorexia. Anorexia is common in malignant patients. Patients have malignancy because the malignancy affects the appetite of the patient. Severe sepsis patient, sepsis affects the appetite of the patient also and lead to anorexia. Many malignancies of the oral cavity or the esophagus leads to affection of the nutrition of the patient. Patient can't swallow or obstructed, so the patient can leads to malnutrition. Repeated vomiting or gastrointestinal diseases or gastrointestinal malignancies affect the absorption of the nutrients which the patient take. Malabsorption syndrome. Malabsorption syndrome leads to absorption of the nutrients and the inflammatory bowel diseases. Inflammatory bowel disease affects the nutrition by decreased absorption, decrease the effective absorption of the small intestine, and after operations, most of the inflammatory bowel disease patients, like Crohn's disease, have multiple operations with removal of parts of the intestine, resection of these parts of the intestine, leading to shortening of the intestines. It's called short bowel syndrome. Short bowel syndrome decreases the effective absorptive power of the small intestine, leading to malabsorption and malnutrition. High fistulas. Fistula excretion of intestinal contents through the skin, or blind loop syndrome, which occur in the patients with peptic ulcer surgery. Long blind loop syndrome leading to malnutrition. Blind loop syndrome is the part of the intestine excluded from the intestine during the surgery of restricted oral intake. In post-operative cases, some surgeons still restrict the oral intake after anastomosis of the intestine for fear of leakage from this anastomosis, or in cases of the post-operative ileus. Post-operative ileus is paralysis of the intestine, so decrease the absorptive function of the intestine, leading to malabsorption. So starvation in the surgical patients have multiple causes, including poverty, senility, ignorance. Anorexia patients can take, or from upper GIT malignancies like pharynx or esophageal cancers, or repeated vomiting from the gastrointestinal tract. Shortening of the small intestine, which is the absorptive power of the GIT, decreasing the absorptive capacity of the small intestine, like in the inflammatory bowel diseases or short bowel syndrome, or patients doesn't take oral. In the cases of paralytic areas, the treatment of paralytic areas, paralysis of intestine post-operatively, is a restriction of the oral intake, or in some cases of surgical intestinal anastomosis. This is the causes of malnutrition in the surgical patients due to starvation. Some surgical patients had a catabolism. Catabolism increase the breakdown of the proteins in the body. This is hypercatabolism. Hypercatabolism اللي هو increase breakdown of the proteins, like in patients with trauma leading to inflammatory response, major traumas leading to massive inflammatory response. This massive inflammatory response leading to destruction of the proteins. Also sepsis leads to inflammatory response. This inflammatory response down the proteins leading to hypercatabolism. Severe pancreatitis, one of the most common inflammations into massive or severe inflammatory response. In the cases of chemotherapy and radiotherapy decrease destruction of the cells and destruction of the proteins. So hypercatabolism occur in the surgical patient due to increase in inflammatory response, like in trauma or sepsis or severe inflammations like acute pancreatitis, or maybe due to drugs like chemotherapy or radiotherapy. So the malnutrition in the surgical patient have two causes: starvation and hypercatabolism. Starvation and hypercatabolism. Hypercatabolism patient take food and take proteins, take nutrition, but these nutrients are destructed in the body due to massive inflammatory response or due to drugs like chemotherapy or radiotherapy. What are the drawbacks of malnutrition? We say that the malnutrition leads to post-operative complications. Most common post-operative complication in malnourished patients is wound healing impairment. Impairment of the wound healing. Wound healing depends on the inflammatory cells. Inflammatory cells from proteins. So decrease proteins in the body, leading to decrease inflammatory response to wound healing. Decrease collagen, which is a protein. Decrease the protein in the body. Malnourished patient decrease the wound healing. So leads to dehiscence, meaning opening of the abdominal incisions, or dehiscence of the intestinal anastomosis, leading to periabdominal or intestinal leakage. And this increases the incidence of mortality in surgical patients. Not only morbidity, not only complications, but also increase the mortality of the surgical patient. Or also this decrease in proteins, decrease in the nutrition on the surgical patient into suppressment of immunity. We know that immunity is derived by cells. Cells is formed from proteins. Decrease the proteins, leading to decrease the number of the immune cells in the body. Decrease in immunity suspects the surgical patient to post-operative infections, most commonly chest infections or wound infections or intraabdominal infections. This is increase the morbidity of the patient and also increase the mortality of the patient. Mental depression and the physical exhaustion. The mental depression and physical exhaustions due to decrease proteins, due to decrease in neurotransmitters. Neurotransmitters also formed from proteins and lipids, leading decrease in proteins and lipids in the body lead to mental depression, physical exhaustion, delay recovery, and increase the hospital stay of the patient. So the malnutrition surgical patient affects outcome of surgery, either increase morbidity, also increase in mortality in the surgical patient. So it's important to assess the malnutrition in surgical patients pre-operatively. How to assess the malnutrition in the surgical patient pre-operative to avoid post-operative complications. There is anthropometric measurements for assessment or for malnutrition in surgical patient. First is recent weight loss. Recent weight loss, more than 10% of the weight of the patient. This is indicate malnutrition. recent weight loss in the last 3 months. In the last 3 months, if the patient lost 10% of his weight, and especially in the malignancy patients. Malignancy patients have a weight loss in the last 3 months more than 10%. So this patient is malnourished, and we must correct this malnutrition preoperative to avoid complications. If the body weight is less than 80% of the ideal body weight, we know there is a BMI اللي هو body mass index. Body mass index is calculated by weight over weight of the patient in kilograms over the height in meter square. The height in meter square. If the BMI of the patient is less than the ideal body weight or is at 80% of the ideal weight, this indicates malnutrition of the patient. Mid-arm circumference. We measure the mid-arm circumference. If the mid-arm circumference is less than 80% of the ideal mid-arm circumference of the weight of the patient, this indicate if the age of patient, this indicate malnutrition. Triceps skin fold. Triceps skin fold. Loss of the triceps. Skin folding, triceps skin folding. This is indicative of fat loss. And there is laboratory parameters. Serum albumin is less than 3.5 grams is indicative of severe protein loss, but it's not a good indicator. Serum albumin is not a good indicator for malnutrition because serum albumin have a long half-life, about 14 days. So pre-albumin level is the most important, more than the serum albumin level. Serum albumin level less than 3.5% grams is indicative for severe protein loss. It's not a good indicator because it has a half-life of about 14 days. The most important is the pre-albumin. Pre-albumin level below 2 milligram percentage is indicative for severe malnutrition. Severe malnutrition. A total lymphocytic count from the blood picture, complete blood picture preoperative is done if the total lymphocytic count is less than 1.10, 1.2, 1.2. Total lymphocytic count is below 1.2 is indicative of severe malnutrition because lymphocytes formed from proteins. So decrease the proteins, decrease nutrients of the body, decrease the number of the total lymphocytic count. This is simple parameters for assessment of the patient preoperative. Assessment of the patient preoperative: loss of weight from the ideal body weight. Loss of 10% of the body weight in the last 3 months is indicative of malnutrition in the last period. Pre-albumin level, not the albumin. Albumin is not a good indicator for malnutrition because have a long half-life. Total lymphocytic count in the complete blood picture is less than 1.2. This is indicative of hypoalbuminemia. Mid-arm circumference and triceps skin folds, the other parameters of the simple parameters for detection of malnutrition in the pre-operative period. Again, to summarize, the nutrition in the surgical patient is important. Malnutrition in surgical patients is called complications, especially in decrease wound healing, impairment of the wound healing, and impairment of the immunity of the patient, due to morbidity and the mortality of the patient after surgery. What are the causes of malnutrition in surgical patients? Starvation and hypercatabolism. Starvation, decrease intake of nutrients, preoperative or postoperative. Hypercatabolism, taking the nutrients, but the nutrients are catabolized, detracted in the body due to increased inflammatory response, like in trauma patients, like in severe sepsis, like in pancreatitis, chemotherapy, radiotherapy, and whatever. How to assess patient preoperatively for malnutrition? Loss of more than 10% of the body weight preoperatively in the last 3 months is indicative for malnutrition. Pre-albumin level, not albumin level. Pre-albumin level is less than 2 milligram per deciliter is indicative for severe protein loss. TLC, total lymphocytic count, below 1.2 is indicative for malnutrition preoperatively. how to support the patient pre-operatively and post-operatively with nutrition. We have two routes of nutrition of the patient, of the surgical patient. The oral route, oral nutrition, it's easy and safe method and the most pleasant by the patient. And patient take oral food, but it's physiological and efficient method for nutrition, but it's contraindicated in some patients. Oral nutrition is oral nutrition is easiest, safest, and most pleasant, most physiological, and a patient is pleasant from taking the oral. The other is enteral nutrition. Enteral nutrition tube feeding. Tube feeding, this occurs in comatose patient. Oral nutrition is contraindicated in comatose patient due to fear of aspiration. Aspiration to loss of reflexes in comatose patients. Aspiration of the food, the pharynx leading to the trachea, the lung, leading to chemical pneumonitis. And a severe pneumonia and chest infection, which will die from aspiration. So in comatose patients, the enteral nutrition is indicated through nasogastric tube. For patients with tumors or lesions in the mouth, pharynx, and stomach or esophagus, these patients can't swallow, and if you swallow, the food doesn't reach to the small intestine, so the patient can't swallow. We put a nasogastric tube for the patient. Nasogastric tube is a plastic tube, is inserted through the nose, descend to the pharynx, descend to the esophagus, and this nasogastric tube put a fluidy nutrition through it to the patient. If there is a lesion in the esophagus, obstruct, and we can't put a nasogastric tube, or a lesion in the upper stomach, we can't put the nasogastric tube. We do what's called gastrostomy or jejunostomy. Ostomy meaning opening. So we open part of the stomach through the anterior abdominal wall. In the abdomen, anteriorly, we open a part of the small intestine and insert a tube through the anterior abdominal wall inside the opening of the stomach, or inside the opening of the stomach, and put the fluid nutrition through it. Nutrition support in the surgical patient may be done oral. Oral is easy, sufficient, physiological, and very good for the patient, pleasant for the patient. But we have some contraindications in the oral feeding, so we shift to the enteral feeding. Enteral feeding through the nasogastric tube. If there is no lesions in the esophagus or in the stomach, it's preferable route in comatose patients to avoid aspiration. Long-standing patients and comatose patients, nasogastric tube may need to aspiration, so it's not preferred for long-standing cases. So we do gastrostomy, opening on the stomach, connected to the anterior abdominal wall by a tube, or jejunostomy feeding. Jejunostomy formulas are draped slowly into the GIT. What are the complications of the tubes? We have tube complications. Obstruction of the tube. This is a plastic tube, have a lumen, may be obstructed by the fluid nutrition taking it, so slipping or blockage. Infection at the site of the insertion of the tube. Aspiration, as we said, aspiration leading to the descent of the nutrition in the lung, leading to what's called chemical pneumonitis. Patient may have pneumonia, hyperglycemia from overdose of the fluid, reflux, and vomiting. The third route of nutrition in surgical patient is parenteral nutrition or intravenous nutrition. It's not preferred method for the surgical patient to give a total parenteral nutrition, but indicated in some cases. We insert a line, mostly central line. Central line, what's the meaning of central line? Central line is a line like cannula. Line is inserted into a big vein, like internal jugular vein or a femoral vein. This is a central line is inserted in the patient, and patient take total parenteral nutrition. Formula is formed of the lipids, proteins, and carbohydrates, and additive materials like zinc and selenium and the vitamins is taken through the IV line. This IV line is a central line inserted into a big vein. This total parenteral nutrition is indicated in long-standing comatose patient with severe illness like severe sepsis or major trauma patients. Regurgitation and aspiration of the food occur in this comatose severe ill patient. So the nasogastric tube may lead to aspiration, pneumonia, so we shift to the uteroparenteral nutrition. Patients have malfunction in the GIT. So gastrostomy and jejunum tubes can't give the patient the nutrition. Patient have malabsorption in the GIT. If the patient take oral or enteral feeding through nasogastric tube or gastrostomy, there is no absorption in the GIT. So we give the patient proteins, lipids, carbohydrates, and additive materials into the IV line directly, because the patient have a problem in the GIT function, in the absorption of the GIT, like short bowel syndrome, high intestinal fistulas, or paralytic AS. Some infants have enzymatic deficiencies, born diseases, including enzymatic deficiencies and malabsorption syndrome. Patients with hypercatabolism, like major patient traumas and major burns and high output fistulas. Fistula, excretion of the intestinal contents through the skin. High output fistula increases excretions more than 500 milli per day. High output fistulas. So the patient is take total parenteral nutrition to store the lost fluids and the lost nutrients in the fistula. So what's the indications of total parenteral nutrition or TBN? The indications in comatose patients for fear of nasogastric tube aspiration, or patient have no function in the GIT, like patient short bowel syndrome, short bowel, small intestine short due to resection or due to multiple resections, or high intestinal fistulas, or due to paralytic illness, decrease the absorption of the GIT or malabsorption syndrome. Patients with hypercatabolism. Patients with hypercatabolism is like major trauma, burn, major postoperative complications like high output fistulas. To restore the lost fluids in this high output fistula, we give total parenteral nutrition. We give the total parenteral nutrition through a central line inserted in a major vein. What are the components of the TBN? Component of the TBN main components is carbohydrates, proteins, lipids, and additive materials. Balanced TBN solution contain water at least 3 liters and have calories from fat and carbohydrates. Adult patient need 2000 kilocalorie per day, but in the hypercatabolic states may doubled to 4000 kilocalorie per day. The protein supplied in the amino acids, normal adult need 70 grams of proteins per day. In hypercatabolism is doubled or near double, 150 grams proteins per day. Electrolytes, calcium, phosphates, and vitamins and trace elements. The TBN containing what we need: carbohydrates, proteins, lipids, and trace elements, sodium, potassium, calcium, magnesium, and vitamins, what we needed. How to monitor a patient with TBN? How to monitor a patient with TBN? To avoid hyperglycemia, the blood glucose level is monitored every 6 hours. Urea and creatinine, due to high level of proteins, lead to affection of the kidney function, should be checked. Calcium, phosphate, trace elements levels, this like calcium, phosphate, sodium, and potassium, is checked. If the fever develop in the patient with TBN, we must check the central line. Central line may be lifted in the patient for 2 weeks, for 2 weeks, but merely to severe sepsis. Central line infection. So we must it changes the central line every 2 weeks to avoid the infection, and must be removed if the patient develop fever from this central line. What are the complications of TBN? TBN is not a preferable method for nutrition in the surgical patient due to its complications. One of its major complications is catheter complications. Catheter complications, insertion of the catheter in the jugular vein may affect the injury. The pleura, the apex of the pleura is near the internal jugular vein. So during the insertion, the pneumothorax occurs. Pneumothorax is fatal and must be detected early post-operative after insertion of the catheter to avoid its major complication. If the catheter is position is maldirected and affect the heart, leading to arrhythmia of the heart, infection in the veins, thrombophlebitis of the veins, and sepsis, catheter site sepsis, and air embolism, pressure on the neck veins, negative pressure leading to air embolism. So the catheter must be blocked all the time except at the time of taking the TBN. So the complication of the catheter is a major complication of TBN therapy. Pneumothorax, infection at the catheter sites. The catheter may reach the heart into arrhythmia, and lastly air embolism, which is fatal. There is a metabolic complications, high glucose intake leading to hyperglycemia, low glucose intake leading to hypoglycemia, fluid overload, increased intake of water in the TBN, hyperosmolar dehydration, increased osmolarity of the TBN leading to hyperosmolar dehydration with decrease الwater intake. يبقى maybe fluid overload أو fluid dehydration, hyperglycemia, hypoglycemia, decrease the water, increase the water, electrolyte imbalance, hyperkalemia, hypokalemia, hypercalcemia, hypercalcemia, hepatic cholestasis, and later on cirrhosis, cholestasis of liver due to decreased excretion of the bile, decreased excretion of bile due to decreased intake of the oral, decreased oral intake, increased oral intake, excretion of the bile from the liver, decrease in intake leading to decreased excretion of the bile from the liver leading to hepatic cholestasis. So the metabolic complications of TBN may be hyperglycemia due to increased glucose intake, or hypoglycemia due to decrease glucose intake, fluid overload due to increased water intake, or fluid dehydration due to decrease fluid intake, and hyperosmolarity of the TBN, electrolyte imbalance, hyperkalemia, hypokalemia, hypocalcemia, hypercalcemia, and maybe hepatic cholestasis and up to cirrhosis of the liver in long-standing cases taking TBN for more than 3 months. Thank you.